So I'll be covering just about history is the most important thing from the point of view of making an accurate diagnosis. Not only that, but it also predicts to some extent the functional recovery that we expect, and of course, how to manage the patient. And no doubt that we make a very good rapport with the patient and we get the trust. Okay, and trust and the familiarity that we need with the patient. Of course, in case you go through the books, you will find that we have lot many things. There is a method. In case you go through this method, you will never miss anything. This is from Braden. And primarily, all the patients have to go through this. And there are a few things where we need to do a little more for the spinal cord injury. And in history, it's very important to know who is giving the history, and whether it's the onlooker, the patient himself, the caregiver, or ambulance staff, or the patient doesn't even remember, and how much reliable it is. It is very important to write on the top so that whether we put much emphasis on the history or not. Most of the times when we talk of the chief complaints, we start with what the patient says, and it all depends upon what's the stage of that injury. It is not by the judgment as we normally see weakness in the lower limb, loss of control over the bladder bowel and things like. So it depends on when the patient comes to you, duration of the injury and the relevant complications. Patients may come only for the sexuality, only for the bladder, only for the pressure sores, and that is a chief complaint at that particular moment rather than the weakness and other things. So these are the list of complaints that most of the people would have, but you have to give it in the order of duration as well as the priority that the patient gives. The mode of injury gives us an idea about what is the type of injury that you are expecting and what are the other associated injuries that you may have, and depending on how the patient fell, what was the position of the neck, what was the position of the body, like you saw in the couple of slides before, it will give us what kind of an injury the patient would have, whether it's a facet injury, vertebral injury, and other things. Many times when the patient is unconscious, we are not very certain about whether we suspect a spinal cord injury or not. And when we have unconscious and we don't have the appropriate history for the spinal cord, it may delay the diagnosis. It's very commonly associated. And many times when the patient is unconscious, we don't suspect spinal cord injury, we may further damage the spinal cord by unnecessary handling. How the patient was carried and how he was lifted, how many people did it, and how they transported. We have seen somebody takes the patients on the arms and the legs, and they even transport sitting on the motorcycle with one person in front, one person behind, and the wheels furthering the injury on the feet or burning the feet, and the way they are transported furthering the spinal cord damage. So it gives an idea about what is the type of injury and what is the furtherness to the injury, which is damage, further damage caused to the spinal cord and other things when they are lifted and transported. When they are brought to the hospital, ABC of course is the most important thing, consciousness. And we look at the spine, we have to properly rotate the person with 3 persons at least, preferably 4, to then see bruising in the spine, and check for the other associated injuries from the head to the toe, and also the neurological status. A quick thing. The initial treatment, what was done, how was the immobilization, how long immobilization was done, whether orthosis were given, collars were given, belts were given, traction, what kind of catheterization for how long, what kind of medications were given, whether surgery was done or not done, and in case surgery was done, whether the expectations from the surgery were told to the patient. Majority of the times, patients feel surgery has been done or even stem cell transfer has been done, and we don't have to worry about doing any further rehabilitation that is on big block. So we have to know what was the outcome of the surgery, and whether the surgery changed the neurological status to the better or the worse at the time of doing that. Then history about a course in the hospital. How long was the hospitalization, what was done, the type of bed which was given, and mobilization was started when and how was the mobilization done. And any change in the status we forget to mention during the course of the hospital in most of the histories that we come. Spinal shock. How long was the spinal shock? What was his status at the time when you examined him? When did the patient return from the spinal shock? The total duration that also has, to some extent, a mark on the prediction of the outcome. There are so many complications which occur, and you have to ask about each of these complications, about all the systems that are mentioned here, and take appropriate history according to that, so that we know that the patient has what other things to be treated and to be managed. Bladder and bowel is one of the important things. We have to not only check what is the present status, but what was the previous habit of the person prior to getting the injury. That is also important. And when the patient has been managed, what kind of catheter, how they pass, whether they use catheter or not, or they use thing, what is the frequency, dribbling, leakage, and accidents which occur, whether they are smelly or not, all those things matter in the ultimate rehab. Sexuality, many a times in the past people used to forget about whether they have to talk about it or not, they used to omit it. We have to talk about the pre-morbid as well as the present status, all inclusive, the desire, erection, ejaculation, in the lady's menstruation, whether they had any attempts and what was the experience, whether they had any premarital experience, or in case they were not married, whether they had any experiences or not. That also makes a lot of difference. If the patient had been lucky and they had a rehabilitation intervention, what was the type of facility that they had? And what was done during rehabilitation? We have seen people being treated in the trauma center at AIIMS, and they have been made to stand in the parallel bars for years together with the calipers without giving any upper extremity strength. And what was done? What was achieved? For how long it was done? And whether after the rehabilitation intervention they carried on doing it, and what was the ultimate outcome, whether they could use it in their real life or not. All these are very important things. I say that we mostly take about 45 minutes to 1 hour history. In the real world, in the examination we give you much less time, because by the time you feel that you have more experience, and sometimes you can omit things, and examination takes another half an hour to 45 minutes. So 1.5 hours is usual, but covering that in 25 minutes is a little off. So what was the condition at the time of discharge when the patient is sent home, and changed in the status since injury? What kind of medications the patient had been having, and what was the medications given at the time of discharge? The kind of appliances, the ambulation status, short distance, long distance, the ADL status, self-help devices being prescribed, bladder and bowel status. This is the condition at the time of discharge compared to what was there at the time of injury. And after discharge, is the patient going home to another facility, to another hospital? So all this, and whether the patient, in case he was previously admitted and discharged, whether he was able to carry out what was told to him, and whether there were architectural barriers in cases coming to you for the second time, and how he is managing at home, whether the vocational and the educational goals which are given to him are being followed, and what are the problems with that, and how he is managing the prescribed short distance and long distance ambulation, and whether he had any further problems after discharge, change in the status, furtherance of the injury, improvement, what complications. Many patients within a month come back with bladder infections or with the pressure ulcers. The sexuality, interpersonal and the financial problems, whether they have a caregiver. Unless we have a caregiver at home or a family members for the support of the person, that rehab cannot be completed. And sustenance of ambulation. Many people who make them stand and walk, and they never walk and stand again at home. And the vocational goals, whether they have been achieved or not. Of course, medical history, major illnesses, medications because of that, surgeries, and specifics about the bladder and bowel, these are all important things. Personal history is again most important, and you have to look after so many things that you look at. And very important is the psychological history, their mental status, whether they are angry, whether they are depressed, whether they have frustration, whether they have been able to resolve the things, and the determination to come back to life. That is the important thing. Acceptance of the condition. Unless the person accepts the condition, he doesn't participate in the rehabilitation. So it is very important if we have to work for the rehabilitation. And participation in rehabilitation is absolutely dependent on the acceptance. Ask this question and ensure that the patient realizes where he is and what he has to do. Otherwise, they'll keep waiting for the recovery to come. The type of family the patient is having, earning members, how much earning, how many dependents, and there are people who have nothing and they spend everything, sell their houses, the family medical history, and whether we have a caregiver and who will be carrying on family. We have identified one person so that we can depend on that, one or two persons. The earning members in the family, financial status, the expenditure incurred, it may be running into lakhs. The whole life savings of the family, they are under loans, and what are the resources we ought to know, whether they are in debt and whether they are able to continue the rehab, because it's expensive to carry on, not just from the point of view of even if you give free services, it's expensive to carry on rehabilitation. The social support and the history, family, whether the person goes back into the society and is integrated back into the society, or is simply lying in the chair or sitting in the chair or lying on the floor looking at the ceiling. The vocational history looks after all this. Whether the person is trained into something, does a kind of education, whether he has any recreation or hobbies which can be converted into a vocation, and the kind of finances the person has. And when the patient goes back to work or education, whether he is reinstated or with a modified kind of a way, or it has been given some alternative kind of a vocation or education. And when they go back to work, every place is not adapted to the person with disability, whether the attitude of the employer or the architectural barriers are hindering that. Very important thing is the house. What we usually do is make a person bring the drawings or check the size of the rooms, take the photographs, approach to the house, whether we have steps, we have ramps, how much is the distance from the road, and what kind of a road that we have, the barriers on the way, and what modifications according to the architects should be done, and whether that has been done or not, and when they are going back home, whether it is being given to the patient or not. Of course, examination, many people just forget about doing a general physical examination, which gives us a lot of information. And we have to look at two things, neurological as well as a spinal examination and a head-to-toe examination. It's important to know the conduct with the patients, that we have to be treated with dignity. I have seen patients lying absolutely naked with nobody with the doors open. And exposure should be as much as necessary, but you have to check everything, including the genitalia, the anus, and the other structure. So look at the hygiene when you touch the patient. The general physical, of course, you have to go through all that. The neurological system, of course, we have a system here, and we ought to check, importantly, the handedness, right-handed, left-handed, which is dominant, the consciousness, the orientation, higher mental function, because all that will give us an idea about the ultimate outcome that you can expect from that. Most of the patient candidates who are examining the patient with spinal cord injury omit the use of, check the cranial nerves. Never ever forget. You never know that the head injury many times is associated along with the spinal cord injury. Spinal cord, the cranial nerves are commonly affected. The motor system, we have so many things to be checked about. Check everything. Use goniometry for range of motion. The MRC grading, muscle charting for the thing. The modified Ashford scale for the spasticity or other scales for the spasticity and spasm. Of course, the Asia chart is important to categorize and give a good idea about the classification of the system and prognostication. And we have so many parameters, but it's a quick method to find out the neurological and the motor and the sensory level here. And of course, you all must be familiar with it. It doesn't give absolute information, but it's a good way to classify. So we know that we have key muscles for the upper extremity and the key muscles for the lower extremity, and of course the sensory system, of course, that goes along with that. In the chart, we have only two types of sensations in Asia, but these are the sensations that you have to check for every patient, not just go by the Asia chart. And we also have to check all the muscles that you can, unless you are in a quick examination in the first, when the patient comes in to check the level and things like, but in detail you have to check every muscle of the body that you can. And reflexes, you know what is the level, and all the superficial and the deep reflexes, including abdominals, bulbocavernosus, and things like. And when you check the spine, because we know spine is at fault in spinal cord injury, we have to check for all these signs that you see here, and very importantly the scar description, which also gives us an idea about the area which would have been immobilized. Check the spinal movement only when you know that it will not harm the patient. The bladder and bowel, of course, you all know the type of drainage, and in case you can check the urine, the PR examination, these are all important. I can't go into the details of everything, but only enumerate. The functional examination, there are various systems like film scoring and other scoring. So you check on what kind of scoring that will give us an idea about the independence that the patient is having. And never ever forget about the other system examinations for the cardiovascular, respiratory, abdominal, genital, urinary. Check for the skin from the head to the toe, where there are pressure ulcers and what's the grading of the pressure ulcers. And many a times people forget about checking the range of motion and the joint contractures, deformities. It gives us an idea about what is the restriction in the joint, how they are going to come in the way, and whether there are heterotocossification and things like. And commonly deformities are there in long-standing patients in almost all the joints. So check all the joint range of motion with a goniometer. Be abreast with how to do goniometer. And when the patient has been prescribed some appliance, what kind of an appliance is it, and whether it is appropriate for the patient, we will expect you to know. Whether it's a wheelchair, caliper, crutch, walker, or it's the self-help device. So check everything that is there. Most commonly, as we've seen in the examination, patients, the candidates in the PG exam forget about giving the past medical history. They forget about asking sexual history. The females don't ask the males, males don't ask the females, or they are so scared of their own sexuality that they don't ask. The hobbies and interests are a very important thing from the point of view of not only recreation but also to convert them into vocation. Cranial nerve examinations. The deformities and contractures, people don't talk about atrophic changes or other things, they forget. So remember to include this. Most of the people can do a neurological and a spine examination, but they forget to do this. Practice doing this surgery. Summary. We have seen a very good way after you finish history, give a summary of 2-3 lines in the history. When you do the general physical examination, tell us about the positive findings so that we know what is to be looked at. And systemic examination, salient positive features. And always write the summary of 4 to 5 lines. Practice that all the time whenever you are seeing a patient, so that in the examination you do not write half a page worth of summary. That will be very boring for the patient. In the end, write about the problem listing, and the problems don't just have to be weakness, bladder, bowel, and things like that. They have to cover all that the patient is suffering from. If you have done a good history, good examination, you will know what all is the problem and what for the patient outcome and what else you see is a problem that needs to be sorted out. That will give us a guide about the management, and in the end we will naturally ask you about what do you expect of the patient immediately and the long term, and after the patient goes back home, what you need to do and what change you can do as a rehab person in that person, because that is what is important for the patient. And that's about it. So start from the current status, not just the patient has come only after 1 year and you start from I will do the immediate management like this and that. Not a chapter in the book, but start with what the patient needs. Thank you very much.
both the same. And this is actually memento. This is a Madhubani painting.
Thank you very much.
Sir, एक photo.
Doctor. Okay, there is no other specialty doctor. You are a PMR specialist there. You are working at there. So how to manage from the pediatric perspective?
Rehab in Bangkok. I've been asked to speak on acute phase rehab of SCI in the IAPMR center. As you all know, acute spinal injury can cause flaccid paralysis, loss of spinal reflexes, loss of sensations, loss of sweating, loss of sphincter tone, and blood ball dysfunction, affecting at the cervical, thoracic, or lumbar level of the spinal cord. The initial care, we have to immobilize the neck with a foam collar, but change to a 2-piece 7-inch collar as soon as possible after assessment or surgery to avoid secondary complications like pressure area, venous obstruction, or aspiration. Also transfer these patients very effectively using slide sheets or with a bed slide in the commercially available preparation. As you all know, no pharmacological agents have been proven to improve recovery in spinal cord injury, so stop steroids as soon as possible, that is when the incitation is over, and aim for normal perfusion pressure and oxygenation. Always remember, people can have simultaneous brain as well as spinal cord injury. Both can coexist sometimes. So not only look for spinal cord, also look for brain injury signs, do GCS scale as well as pupillary responses. And do it hourly in first 24 hours and then 4 hourly if required. This spinal cord perspective per se checks sensory level and motor function, and at 72 hours do a full detailed ACI evaluation to see in detail the impact spinal injury on the impacted person. The most common problem in the acute phase or in the ICU is autonomic instability, which can affect heart rate, blood pressure, temperature regulation, and respiration. Bradycardia can easily occur because of unopposed legal activity. The thoracic vein input is being damaged. They will require continuous heart rate monitoring and SOS treatment with orsipinamide, which is an anticholinergic medication. One remember elderly people or those with 17 and brain injury check with thyroid profiles also, as low thyroid can also contribute. Also look for other medications that can cause bradycardia. Now, blood pressure is affected because loss of vasomotor tone will cause vasodilatation and hypotension. And this phase may shock that will last several weeks. This hypotension should be treated aggressively as it can cause secondary perfusion, lack of perfusion spinal cord also. Blood pressure is monitored continuously in the ICU. Ensure we should be able to give adequate fluid to the patients, don't overload. Some patients with very low blood pressure will require anastomotic support. And when you have anastomotic support, you can use the oral merocrine, which is an oral antiallergic agent, or fluorocortisone. But as remember, don't overload the fluids because pulmonary edema. The muscle temperature control means ability to sweat, shiver, vasodilate, vasoconstrict to maintain temperature. It's called as hypothermia, and most commonly is hypothermia. The temperature should be measured 4 hours in the acute stage, measure the rectal temperature if possible. Ensure adequate clothing or bedding in cool environment and artificial cooling in the hot environment. Because each person in the acute stage does temperature regulation, the body will take on temperature. If it's more hot environment, little more hot, little cooling, and vice versa. Respiratory difficulty is very common in spinal shock, but it depends on the level of injury. People who have severe involvement, diaphragm neck, because both muscles are paralyzed, they will require mechanical ventilation with initial intubation and then to a tracheostomy. Those who need long-term ventilation will require pacing of phrenic nerve of a diaphragm. From speech at T6 levels, the intercostal muscles are paralyzed, diaphragm is still okay. They need some of support in the beginning with nasal prompts, oxygen support. T6 to T12, the abdominal muscles are paralyzed and there are some decreased function. So assess the respiratory status, the pattern, the effort, the ability to cough, auscultate chest, monitor SpO2, do ABGs, intubate and ventilate if respiration is inadequate, and maintain strict VAP strategies to prevent pneumonia. Nurse them head up, but remember, tilt the entire bed up, the spine should remain in line. And when at a later stage, you ask people to sit up out of bed and their mid-dorsal paraplegics, the abdominal muscles are paralyzed, the breathing can be worsened in the breathing position, ask to sit up. With them lie down, semi-recumbent position also. And ensure that the diaphragm is not distended, because that will further reduce the chest capacity, insert NGF required, reduce the IDS. Start chest physical therapy for assisted coughing, postural drainage, airway clearance, breathing techniques and exercises. In a simple appendix parameter, there is no tubes, and start explorating muscle as early as possible. In persons who have diaphragmatic weakness, you can start EMG guided diaphragmatic stimulation, which is very helpful to diaphragmatic contractions. People who are on ventilator but can't cough enough, use something called as cough assist device. So cough assist device is a insufflation fixation device which can suck out oxygen from the deep inside the thoracic cavity, the chest. For example here, now there are machines with a thoracic vest which can provide deep exhalation. It's a good thing to have in ICUs. And patients who are difficult to wean, we should wean them to a portable ventilator, portable BiPAP. If they have no tracheostomy with a BiPAP, if they have tracheostomy, thin tracheostomy, put on a portable vent, with get the ICU as early as possible. Add mucolytes, agents, add nebulizations accordingly. If you have too much suctions, too much secretions, add glycopyrrolate nebulizations. If there are more of spasms, give steroid nebulizations. If they are thick secretions, give ventilator nebulizations. It depends what the person. But the aim is to wean out the ventilator as possible and get out of the ICU to the rooms where he can start as early as possible. Persons who have involvement of diaphragm with the height of tetraplegics, usually C to C3, they will require some alternative arrangement whether they have independent. So it's called as phrenic nerve pacing. Equivalent candidates are people who have high cervical spine injury, C to C3, but an intact phrenic nerve, a normal nerve function at chest compliance. Do a pre-implantation screening, either by a nerve connection with the phrenic nerve, which is difficult, but visualize diaphragmatic movement in fluoroscopy. You should go up by 2 levels at least in fluoroscopy. The advantages can be off the ventilator, they can speak better, less expiratory secretions, less emergency care required, not in the ICU, not in the ventilator. Skin is the biggest organ in the body, has the highest compression areas, which has to be monitored very strictly. A baseline skin assessment at the time of admission. For all patients, a pressure, injury, prevention plan will be commenced, should be assessed on specific scales. Pressure matrices, lower air loss, aortic pressure, or GI should be approved, be started. Reposition every 2 hourly, given time of admission. Care with temperature of the washes, if you use hot or cold devices, it can cause burns. Maintain hygiene, daily wash keeps them clean. Often when the hard call, people will wear, actually remove them once and just underneath. Maintain adequate nutrition, good skin integrity, and skin should be fully inspected once per nursing shift, along with 2 hours return. Always remember, all these type of things are available commercially, but only specialty beds like air fluidance beds or low air loss beds, only these beds are the actual pressure relieving devices. It's called special laser protection technology to detect the pressure. No other type of over laser protection mattresses, the pressure is still going 25 mm mercury, so you need to turn the patient. So if you can use specialty beds, it's better if it's feasible. Bladder, another big problem in the acute stage also. The aim is to prevent infections, maintain continence, find a best way to empty the bladder. It depends on the level of injury. Is it type of upper or lower bladder? But remember, in early acute phase, inward catheter should be used. And always use lidocaine lubricant to insert catheter. When the patient is stabilized, opiate doses are being removed, try to change to a 6-hour lead-in catheterization by the trained staff. Long-term will depend actually on the hydrodynamic findings, but in the initial stage, maintain good hydration, use the risk of UTI and kidney stones, good hand hygiene by carers, patient perineal area to reduce infections. Always remember, priapism may occur in boys and usually self-limiting and not a contraindication to catheterization. Catheterize properly early, maintain hygiene, and change to CIC as early as possible. Bowel function will also be lost with lack of renal control. In addition, medications such as antibiotics, opioids, lack of mobility, lack of food, lack of fiber intake, lack of fluid intake, all affect bowel function. So it recommends a bowel management program as well as bowel sounds are present and the enteroidal feeds are started. So in the acute phase of spinal shock, to add some appliance on the enteral feeding, level dilatation early to ensure adequate nutrition, fluid and fiber in the feeds. At least 30 of fibers to go in the feeds right from the time starting. When the spinal shock is resolved, patient is able to sit. There is a bowel routine, which depends upon the age, the bowel function, level of injury, pre-injury status, the support available. Persons can have a reflex bowel, a flaccid bowel, and this combination of both. The common problems in bowel management are constipation, which is caused by inefficient fluid and fiber intake, insufficient appliance, medication like anticholinergics, opioids, or immobility. Treatment is increased fluid fiber intake, give some more appliance, give more laxatives as possible. Second is impaction, which is caused by chronic constipation. If patient only there is a liquid overflow, corresponds to their diarrhea, use a contact stimulant, cognitive laxative, and tricyclic evacuation only if necessary, with no suspension or anemia. Third issue is diarrhea. The common reasons are change in diet, antibiotics, excess of laxatives, or high level of infection. Treatment is to adjust the diet, reduce the laxative, send a stool specimen to internal X-ray, infection is suspected, and add probiotics. The fourth issue, people are on higher antibiotics. They can have significant diarrhea, false smelling, green colored, always suspect clostridium difficile infection, and send stool for C. toxin. If it's positive, patient need contact isolation and start vancomycin for at least 14 days period. Such patients. Nutrition is also very important in the acute stage. Insert the resonated tube as early as possible to reduce the risk of vomiting and aspiration to bladder virus in the beginning, and start enteral feeding as early as possible. The dilatation referral. People can have gastric ulcers because of the stress, add up pantoprazole if possible. Also remember, many patients with cervical spine injury who underwent anterior fixation every switch. So in these patients, always check for swallow before starting oral feeding. Also, the swallow study can be done now. And those patients who have polytrauma along with SCI, put a tracheostomy early to optimize feeding and nutrition. People who have tracheostomy with isolated spine injuries, difficult to wean off, you have to follow protocol for decannulation. See them early and do a dye test with some current liquid equivalent. Check if it's coming in the suction or not. If it's coming in suction, called as dye test straight. It's not that way. Easy to deflate tracheostomy cuff and put something called as a speaking valve. It's a passive one-way valve which will allow person to speak. You can get it Dept cuff for one number of hours. Then do a test called as video fluoroscopic swallow study. The exact fluoroscopic units. Keep the patient there. Give different consistencies of food. Look where the food is going. If it goes straight, it will be not it doesn't comes like immediately splendid in aspiration. You get to the where the food is going, it goes straight to the mouth, it goes straight to the comes in front, like the precision. And then look for voluntary cough, look for reflex cough, T2 capping, swallow assessment, dye test fast. You can decant the patient very successfully, even in the ICU, but not in the AT units. Also, that's a big problem even in the initial stage because of autonomic nervous system involvement. And remember, a medical approval is required before sitting. So ensure that is not affected without any instructions. In document, start sitting the case records. To avoid push-through hypertension, use anti-embolic stockings, calf compressions, abdominal binders, take some irritable, notated FE is also available. If people have partial hypertension, use fludrocortisone, 100 milligrams, 1 in the morning. If you're going to try dosages also, it will help. Pain presents early in the ICU stage also. It can be a nociceptive pain, more common, and just a neuropathic pain. It can be muscular, visceral, above at or below level. What we see most in the ICU settings, the nociceptive pain, which is muscular primarily, is an inflammation, mechanical instability, and muscle spasm. Visceral pain, sometimes we see in the ICU in the early stage. Neuropathic pain can be seen at the above level, compared to neuropathies. At level is the same injury. So you have the pattern to follow. Step 1, give non-opioid like paracetamol, diclofenac. Step 2, give weak opioids plus minus non-opioids. Step 3, strong opioid like morphine, pethine, fentanyl. And step 4, can always do local injection to reduce pain in these patients. Another complication is joint contractures, which can set in very early in the acute stage also in the ICU. So the lack of abnormal muscle tone, lack of movements, improper positioning, because contractions involve physical therapy, occupational therapy, orthotics early, for range of motion, providing splints, and for upper limb and care. Another big complication which can happen in the ICU setting also sometimes is the autonomic dysreflexia. This is because the patient will have level of energy more above T6. There is an abnormal excess response to a nocturnal level of injury. The common reasons are full bladder, infected bowel emptying, pressure ulcers, tight clothing, fracture, surgery or pain. People have signs of hypertension, fever, pounding headache, the skin rash, flushed skin, the dilatation above the level of energy is sweating, where the constriction growth would cover skin, ventral vision, anxiety, and so on. If you see hypertension, get the blood up, no relief, set the patient up, get relief very good. If not, check for bladder distension, retention, and obstruction. With normal bladder, check fecal impaction, give a little evacuation in anemia, screen for UTI. If normal, then the back-to-back catheterization or ligation or replace the catheter. If both are not there, then investigation for abdominal, genetic urinary, skin, and vascular supply. 90% of time, treat remove the source, patient will be better. If not, it will use rapidly acting antihypertensives. Very common drug is oral something will rapidly help in such a. But it is really required. Treat the cause, patient will be better. Thromboembolism can happen in the ICU settings. There can be a thrombus in the lower limb veins, the deep venous thrombosis, or it can migrate to the lung, or it's probably embolism, which can be life-threatening. 20% patient very widely in different settings. Patient might have complaints of swelling, pain, rising temperature in the legs. Always remember, it can be a sympathetic dystrophy, it can be cellulitis, it can be impending HO. Both sides of xenography, if you don't do much. What is most commonly used is ultrasound Doppler study, easily available, you can do it bedside. And if you diagnose it, to prevent, first prevention is limb elevation, use pet stockings, pneumatic compression, RM joints every day. Either give acute heparin or a low molecular heparin like enoxaparin, 60 mg SC once in the evening. Once it is diagnosed, there for anticoagulation either by heparin, low molecular heparin, or newer oral anticoagulants. But if say a person has a DVT, rest, elevate the limb, at least for 10 to 14 days, no exercises, and do full perpetual anticoagulation. If such a person has DVT, sudden respiratory arrest, without aspiration, shift to ICU immediately, do a blood gas analysis, and do a VP scan from angiography to look for thrombus in the pulmonary arteries. If it's there, an option is to pop retrieval. Patient is very sick or continue anticoagulation. It will at least 6 months in that time. Hypercalcemia can be within the acute stage also. Very common in younger men with complete injury. The common signs are nausea, vomiting, decreased appetite, lethargy, and polyuria. And hypercalcemia will occur first. When the calcium burden becomes so big, it will compensate hypercalcemia. Initial treatment is with hydration IV fluids, and if it persists and cause problems, it can give IV palmitate infusion, which is the best way to reduce calcium levels in such patients. Head-on calcification is the formation of normal bone in normal size within near large joints with head and spinal cord injury and the shoulder, elbow, hip and knees. These patients always have hypercalcemia first. It's a late complication, but in some patients who have beyond ICU stay, especially cervical spine injury with concomitant TBI, they have in the ICU also. The present is a low.
Yes, it's coming back, light is coming back. It's more clear. No major problem.
The grief and anxiety, modify the environment, interpersonal relationships, completely physical and mental problems. People have a gross psychological impact of spinal cord injury. It is devastating to persons and families. We have built reference to social work, clinical psychology, counseling, and use the support groups. Everything within India have a SCI support group. Involve them early. Work their counseling with such patients and their families. It helps a lot. Sexual function is a great concern to families and patients in the acute stage. We did not talk about the patient that was under the SCIs. You have to ensure that counsel the family that puberty will occur with the children. For female, pregnancy is possible, and for males, it may be required for erection, ejaculation, and fertility. Counsel them early. It's a big problem between younger population. Just to conclude, acute SCI has devastating consequences on the person and their families. Initial immobilization and neurological assessment and diaper protocol. Autonomic dysfunction including heart rate, blood pressure, temperature, and respiratory management is challenging. Appropriate bladder and bowel care manipulation by ICU. Nutrition is important. Beware of dysphagia, which is anterior cervical fixation patients. Decussion protocols are required, especially in patients with tracheostomy cervical spine. All efforts to be made to prevent secondary complications and provide early treatment for pressure ulcer, contractures, DVT, HO, dyspepsia and pain. Keep in mind psychiatric, psychological and sexual problems and provide necessary counseling. Multidisciplinary team approach and also empathy is required to treat such patients. Thank you very much.
Thanks to Dr. Abhishek. Yes, sir. Please come, sir. You take this on behalf of Dr. Abhishek Srivastava. I'll take it back again to you.